Good morning guys, welcome back to our healthcare series. Welcome back guys, long time no see. I'd like to say belated happy Mother's Day, belated happy Father's Day, and belated happy birthday to me. For today, we're going to have a healthcare topic, and that is the critical care assessment, A to Y. I hope this helps our healthcare professionals like our nurses and doctors, especially during this time of pandemic. But first, let's define the word assessment. So before we start, we'll just define the word assessment. Assessment refers to systematic data collection which are related to the patient care, including their health problems and health needs. This will serve as a guide for healthcare providers in formulating smart plans or goals, listing effective interventions, and this will serve as reference as well when it comes to evaluation of care and or treatment. Let's go to letter A, Airway. Let's start with Airway. For Airway, we need to include the following in our assessment. We need to check if the patient has got any obvious airway obstruction such as phlegm or foreign body, and check if the patient is self-ventilating or using his own airway. Also, take note if the patient has got any airway adjuncts such as oropharyngeal airway and nasopharyngeal airway, and take note of the size of these adjuncts as well. And then for your ventilated patients, check the following. Take note of the endotracheal tube, including its size and its position as well, especially the position. So checking the position ensures that the tube hasn't moved, which is detrimental to the patient. For example, we have endotracheal tube or ETT size 8 tied at 23 centimeters at lips. Next one, we have tracheostomy. Take note what kind of tracheostomy the patient's got, whether percutaneous or surgical. A percutaneous tracheostomy can be done at bedside, while surgical tracheostomy will require theaters or operating room. Also, take note of the size of your tracheostomy. And then our next stop, B, breathing. For breathing, we have the following. Observe the patient's respiratory rate, whether how fast or how slow the breathing is, respiratory depth, how shallow or how labored the breathing is, and then chest expansion. So we need to compare the left and the right side of the patient's chest and observe for symmetrical movement. Sometimes the movement isn't symmetrical, which can be termed as seesaw breathing. And then note for any accessory muscle use, which is a sign of labored breathing, which can indicate low oxygen levels in the body or in the blood. Next, we need to check if the patient is on room air or if he's on any oxygen as well. If the patient is on oxygen, take note of the oxygen delivery device being used. These are your nasal cannulae, face mask, venturi mask, non-rebreathe mask, nasal high flow therapy, non-invasive ventilation, and invasive ventilation. Also check for oxygen saturation as well, alongside these oxygen delivery devices. For your nasal cannula, face mask, and non-rebreathe mask, the following are the amount of oxygen that we can put to your patient. For nasal cannulas, we can put from 1 to 4 liters per minute. For the face mask, it's from 5 liters per minute. And then for your non-rebreathe mask, it's 15 liters per minute at most. And then for your nasal high flow oxygen, be sure to include the following details. Include the flow, which is in liters, your FiO2 or fraction of inspired oxygen or how much oxygen you're giving to the patient, and your humidification level as well, which is in Celsius. For example, your patient is on 60 liters, 60%, and 37. So that means your flow is the 60 liters and you're giving 60% oxygen to your patient. And then we tackle non-invasive ventilation, which can be your continuous positive airway pressure or your CPAP, or your bilevel positive airway pressure or the BiPAP. So for these two, let's go to CPAP. You need to include the pressure, how much pressure the machine is giving to the patient, and the fraction of inspired oxygen or your FiO2 as well. And then for your BiPAP or your bilevel airway pressure, we need to include the IPAP or your inspiratory positive airway pressure and your EPAP, or the expiratory positive airway pressure. And then if your patient is intubated or ventilated with a breathing machine or ventilator, you need to include the following details in your assessment. These details include the mode, whether the patient breathes spontaneously with the machine or on duopap or bi-level or machine assisted. We need to include the pressure support, how much pressure you're giving, as well as your positive and expiratory pressure, or the PIP. We need to include how much oxygen you're giving to the patient, that's your fraction of inspired oxygen or FiO2, as well as the rate which is already given through the machine. And then also note if the patient has got spontaneous cough, and take note of the secretions, including the following details. So note the amount, whether minimal, moderate, or large, the consistency, whether luke or thick secretions, and the quality of these secretions, whether mucoid, mucopurulent, frothy, or blood tinged. We may consider sputum sampling, which can help with the diagnostics as well, and the treatment plan. Also, listen to your patient's chest or auscultate your patient's chest for breath sounds. So, common breath sounds include the following: wheezes, which are high-pitched hissing sounds, such as in airway narrowing or bronchospasm or asthma. We have stridor as well, which is characterized as high-pitched sound, such as in laryngeal or tracheal obstruction. We have coarse crackles, which are low-pitched, bubbling and gargling sounds, such as in fluid overload or pneumonia as well, and fine crackles, which are characterized as high-pitched popping sounds, such as in those with restrictive and obstructive lung diseases or disorders. Next, we have C, cardiovascular. So let's go to cardiovascular. For cardiovascular, we have the following. We talk about the patient's hemodynamics. That means we talk about blood pressure, heart rate and rhythm, and temperature. For the blood pressure, we have three terminologies. We have normotensive, hypertensive, and hypotensive. Normotensive means normal blood pressure. Hypertensive means high blood pressure, anything from 140 or 150s systolic blood pressure or higher. And hypotensive is anything less than 100 millimeter mercury systolic blood pressure. And then you talk about heart rate and rhythm. For the heart rate and rhythm, we have the following terminologies. It can be sinus rhythm, sinus tachycardia, or more than 100 beats per minute. Sinus bradycardia means less than 60 beats per minute. And then atrial fibrillation, which is represented by high heart rate and a funny heart rhythm on your cardiac monitor. And then temperature, we have hyperthermic, pyrexia, or febrile. That means the patient has fever, anything more than 37.6. And then normothermic or apyrexia from 36 to 37.5. And hypothermic, that means a low temperature which is less than 36. So anything from 35.9 or less than that. And then D, we have disability. Let's talk about disability. For disability, we cover the following. We have the patient's general appearance. Does the patient look sleepy? Is the patient asleep? We have the following as well. Level of consciousness identified with AVPU and your Glasgow Coma scales. So what does AVPU stand for? So it stands for alert, verbal or voice, pain, and unresponsive. So check if the patient is alert. Is the patient responsive to voice? Is the patient responsive to pain? Or is the patient not responding at all? For your Glasgow Coma scale or your GCS, we have the parameters eye response, verbal response, and motor response. Just refer to the table for the responses and the corresponding scores, and take note that the best response or the highest score is 15 out of 15, that the patient is fine, he's responsive, he's orientated, and he's following commands, and the lowest score is 3. That means the patient is in a coma. And then we talk about sedation. For example, we have propofol, alfentanil, remifentanil, and dexmedetomidine. So propofol is one of the commonly used sedatives for operative procedures or surgical procedures. We also have alfentanil and remifentanil, which are both pain relief and sedative as well. For patients who are more likely to stay on the ventilator, then the preferable medication for use is alfentanil, but if the patient is likely to be extubated the following day or sooner, then remifentanil becomes the drug of choice. For patients who are likely to be agitated after extubation, likely because of anesthetic agents or sedatives, then we introduce dexmedetomidine or Dexdor. It serves as the transition between the intubated phase of the patient's stay in the unit, for instance the critical care unit, and the extubated phase. Also, we use paralyzing agents such as atracurium and cisatracurium. These medications are used if the patient is not compliant with the ventilator, if the patient is fighting the ventilator, or the patient is simply asynchronized with the ventilator. So that means the patient is hard to ventilate properly. So when using paralyzing agent, take note that the patient has to be sedated as well. And we also monitor the patient if we are giving too much sedation or giving less sedation. In line with sedation, we use this scale as well. This is the Richmond Agitation Sedation Scale, or the RASS. So if you refer to this table, so we determine the patient's RASS score depending on the following descriptions. For example, we have 0, that means the patient's alert and calm. -5, the patient has no response to voice or physical stimulation. That means we might be over-sedating the patient. And then the patient can go up to +4. That means the patient is very combative and posing threat or danger to staff or other patients. Ideally, we record RASS scores hourly. Ideally, we record RASS scores hourly during the day and then every 3 hours at night, but it all depends in your hospital protocol. Part of disability, we talk about blood sugar as well. We identify if the patient is diabetic, is he on any tablets for that or any insulin. We also cover mobility, so we find out if the patient is independent, does he need supervision, or does he need assistance of 1, 2, 3 or hoist for transfer. Let's go to exposure. For exposure, we cover any contraptions attached to the patient, from your endotracheal tube, oral or nasogastric tube, central lines, arterial lines, vascath or vascular catheter, cannulas, and urinary catheter. Also, it includes chest tube or drains. We talk about abdominal drains as well, stomas, urinary catheters, and dressings as well. We also cover skin integrity under exposure part. We talk about pressure areas, wound sites, surgical sites, and if the patient has cuts or bruises as well. And then we have fluids. For fluids, we talk about if the patient... For fluids, we check if the patient has intravenous fluids or IV fluids or IVF, IVI, and include the rate as well. How much fluid is running through the pump? How much fluid are we giving to the patient? Also check if the patient is on any diuretics such as furosemide and spironolactone. So what's the difference between furosemide and spironolactone? So furosemide is one of the diuretics that reduce your potassium levels. So it excretes potassium from the body. On the other hand, spironolactone is a potassium-sparing diuretic, which means it conserves potassium in the system. It spares potassium. Okay, it prevents potassium loss from the body. And then we also talk about urine output under fluids. We have these terminologies. You have polyuria, if the patient is passing more than 3 liters of urine per day. Oliguria, if the patient is not passing enough urine, okay, as measured as less than 0.5 ml per kilogram per hour. And anuria, that means the patient isn't passing urine at all, and this indicates kidney malfunction. Under fluids, we also cover fluid balance. So we have positive fluid balance, even or neutral fluid balance, and negative fluid balance. Positive fluid balance, that means your intake is higher than your output. Even, it means intake is equal to the output, and then negative, that means the output is more than the intake. So to manage the balances, we have IV fluids if the patient is negative balance, if the patient is passing more than what he's having. And then if the patient is on a positive fluid balance, we may give diuretics, or the patient can be placed on fluid restriction as well, depending on the sodium levels too.
Next we have G, gastrointestinal.
Gut, or your gastrointestinal tract. So we talk about the patient's diet. Is the patient on normal diet, clear fluid, soft diet, textured diet, NG feeding or PEG feeding? Is the patient on TPN as well? So we also add the patient's appetite. Does the patient have fair appetite or reduced appetite? If the patient has appetite loss, then we consider dietitian referral as well. And then we have Malnutrition Universal Screening Tool, or the MUST score. This screening tool includes factors such as weight loss in the past 3 to 6 months, or if the patient's been acutely ill or has not been eating for a few days. So a high MUST score needs liaison with the dietitian as well. And that's what we've said earlier, okay? Referral to your dietitian or the patient's dietitian. Part of your GI assessment include the nasogastric tube feeding. So is the patient having this tube feeding? And the total parenteral nutrition as well, if the patient isn't absorbing. So for both of this, we need to include the rate. And then if the patient is being fed via tube, we need to check if the patient is absorbing. As for TPN, it's usually used if the patient is not absorbing. And for TPN, we need to consider sterile technique or aseptic non-touch technique, because we don't want to contaminate the patient's access or introduce any bacteria or harmful organism to our patient's access. Also, we talk about presence of any nausea or sickness or vomiting. And we talk about, of course, bowels as well. If the patient has already opened his or her bowels today, or when the patient last opened his bowels. For the bowels, we use the Bristol stool chart as reference. So this is the Bristol stool chart. So we have 7 types of stools and the following characteristics and their implication. For instance, if the patient has a smooth, soft sausage stool, then it's characterized as type 4. If the patient's stool is watery, that's a type 7. And if it's persistent, then we consider doing a stool sample and putting the patient in isolation. Okay? Just to rule out the likes of norovirus and C. diff as well.
Next is H, hematology.
And then we have hematology. We talk about blood, okay? So we have the blood count. We have the RBC, WBC, platelets, hemoglobin. We also have your electrolytes such as your sodium, magnesium, potassium, and phosphate. Clotting factors. Blood thinners. Is the patient on any blood thinner tablets or injections? And is the patient for any transfusion or is having any transfusion?
And then we have I, infection.
And lastly, we have infection. For infection, we tackle the following. So we take note of the C-reactive protein or the CRP, which is an inflammatory or infection marker. The higher the CRP level, the likely the patient has an infection. We also cover antibiotics. What antibiotics has the patient got? And the patient's control and the patient's infection control status as well. Is the patient in isolation? Is the patient barrier nurse? For example, the patient has got COVID-19 or the patient has got norovirus. So those cases, we need to put the patient in isolation. We also include investigations done for infection, such as blood cultures, sputum and urine sampling, MRSA or methicillin-resistant Staphylococcus aureus swabs, COVID swabs, and immunology screens as well, such as your HIV.
So the A to I approach allows us to properly and comprehensively assess the patients and identify any potential and actual problems or health problems they have. So guys, this ends our video for today. If you think this videos helped you, don't forget to click the thumbs up button, click the subscribe button, and the bell icon as well for future updates. And then if you have topics in mind, feel free to put them in the comment section below. Again, thank you very much, and I'll see you later. Bye!